Welcome to the introduction for episode 3. Today we have Dr. John Starinski, who joins us on the Open Wound Research podcast. Dr. Starinski is well known in the community for research, setting up studies across the country with many different partners. He is a fantastic scientist who also delves pretty deeply into this microbiology of wound healing and wound progress. He is absolutely fascinating in parts in how he breaks down how wounds function at a cellular basis. And I think it's a great podcast for viewers in general, but specifically for those who are more interested in the microbiology of wound care. But I think Dr. Starinski is a fantastic guest, and I hope that you enjoyed this episode on the Open Wound Research podcast. Thank you. Today, we have Dr. John Starinski with us, and greetings, Dr. Starinski.
Hello, good to see you.
Likewise, likewise, and I appreciate you joining us on the podcast. I think you're going to add a lot of value and share some of the great stories that you've told me in passing.
I'm looking forward to it.
Let's get started, perhaps, by a quick introduction relative to your educational credentials. So, Dr. Starinski received his undergraduate degrees in geography, education from East Stroudsburg University in Pennsylvania, in the Poconos region, for any Pennsylvanians watching the podcast. He also received a master's degree in biology from East Stroudsburg University as well. He then moved on and received his doctorate in pediatric medicine from Temple University in Philadelphia, also in Pennsylvania, at which point he traversed across the country, did his residency at the Tucson Veterans Administration Medical Center in Arizona. He has participated in numerous international wound care medical missions, which we'll come back to a little bit later. And he's also presented and published on wound care research, especially around the subject of biologics. He has a long history of medical and educational directorships in the realm of research and clinical development. So, with that massive mouthful, welcome yet again. And what's really interesting is, to me at least, is the breadth of your education and what you sort of your pre-story to wound care. Maybe just to get started, one thing that caught my eye was geography in undergrad. What is that about?
Well, I think part of what attracts me to the work that I do is that I do travel a lot, and having a degree in geography got me to see the world academically before I actually saw it physically. So it was kind of my mission in life to do that, and it kind of worked out the way I planned it.
Even at that early point, though, you were interested in obviously education, and I think you had a minor in chemistry, if I'm not mistaken.
Yep. Yeah. So chemistry was always an interest of mine. I didn't really have the time because I switched over to the college in to Temple to go for because we had a cooperative program with Temple at East Stroudsburg, and before I could finish out a full degree, the minor was it was enough for me. I did teach chemistry a bit in community college though, so that was kind of fun. Or particularly attracted to organic chemistry.
That's brilliant. And then you did your master's in biology. So obviously you were getting into science, obviously teaching some of it, as you've said. So what made you choose biology as your next port of entry?
Well, we had a very good biochemistry professor at ESU, Dr. Anderson, I remember. I took his course in biochemistry, and it just on a graduate level, and deciding what to focus on, he pulled me into biochemistry, molecular biology, cell biology. That's what got me interested, and then it just went from there. So ESU has a strong science program, and the master's there was good. It was challenging, and it was fun. I mean, I remember writing the thesis, and all the rewrites I had to do was it was agonizing, but got through it.
No, that's brilliant. It's funny, East Stroudsburg, as you know, I went to school in Pennsylvania, down in
Hmm.
Philly, and we'd play rugby against East Stroudsburg. So I have a very interesting history with East Stroudsburg because my most memorable moment was getting into a fight on a rugby field.
Yeah, yeah. One of my fraternity brothers is a rugby player. Little guy, but man, he was tough.
Oh, you guys were very tough, very tough. I remember when they came out as a bunch of tall German-looking kids. It was fun. We got into a fight, but we made up and we recovered the way rugby players recover with a party and some beer. So it was brilliant.
I mean, ironically, it's because my wife is has a Scottish his background, and we go to Scotland on a regular basis. Very interested in rugby. I think it's the most fun sport to watch because the
Absolutely.
action never stops. Yep.
Absolutely. I can't agree anymore. It's my favorite too. So you finished your master's degree in biology, and then what made you choose pediatric medicine at that point?
So, for a variety of reasons, I think that the variety of the practice, where you can have a surgically based practice, but still treat patients medically. Um, and then, as podiatry has grown over the years, it's amazing to see how far we've come with expanding both the surgical and medical side of the practice. I mean, a lot of my colleagues, and I'm involved with the Chicago Lower Extremity Surgical Foundation and the this microsurgical group. Routinely now podiatrists are doing reverse muscle flaps, taught to us by plastics, and we've come a long way, and that helps with the treatment with the wound care side of the practice, which really is interesting because every patient is different, which makes that part of the practice very interesting. The routine part of podiatry, the bunion surgery and all that was fun, but then there's only so many bunions you could do before it gets pretty boring. Whereas the Charcot reconstruction side was much more interesting.
Yeah, the Charcot seems to be a point of deep interest in the pediatric community. Anytime I go to a pediatric conference, Charcot's first and foremost, and Dr. Charcot's work. Before I started hanging out with you rowdy podiatrists, did not know much about the Charcot foot.
So nobody really wants to attack that problem. I mean, it's first of all, it's not reimbursed at a very high rate, and it's their long surgeries. 5.5 hour surgeries. Patients tend to be non-compliant. It's challenging, and every one of those cases is different. It makes it interesting. You're not doing it for the financial reward. You're really doing it for the love of the work, and that's kind of why I like that part of the practice.
Talking about the love of the work, talk to me a little bit about your work at the Veterans Administration at Tucson, where you did your residency. I mean, that is a challenging setting to work in.
Well, that's where I really got focused in on the wound care side. We had a tremendous department at Tucson in handling complex wounds. In fact, we had patients come from as far as Midland, Texas. And they would drive to Tucson to see us because they got really the best care there. I remember best story I have on that is I had a patient, an oil worker, with a diabetic wound that I was treating. You do a surgical excision, and then you follow up with treatment, and you hope that they're compliant. But every time I saw him, I'm like, man, you have a long drive. And one day he said to me, "You know what, Doc? It's not a bad drive. Midland and back is just a 2 6-pack drive."
It's an interesting way to keep time.
That's when your blood pressure goes up. When you're diabetic, it's on you.
That's funny. And, I in the veterans world, in my prior life, we worked with a lot of veterans in nursing homes. And again, you've articulated they're funny, they're engaging, but they can be very difficult patients at times.
They are, but they're awesome people. And one of the companies I'm working with now, we're going to get very heavily involved with research on in the veterans system, and working with the Veterans Administration and their research side. It's much more focused and impressive than people think. So having this company in particular is veteran owned. So I have a soft spot in my heart, obviously, for the vets, and I think getting them involved in research is valuable. Uh, it's and having a research group, as each of these veteran visits have, is pretty impressive as well because they have the staffing to help the research go forward.
That's brilliant. And so, how did you get into wound care? So you finished over at the Veterans Administration. And then obviously you were doing a little bit of wound care at that point, but how, at which point did you really decide to get engaged in wound care as your primary initiative?
Well, that's a great question. I had a general podiatry practice for I don't know, maybe about 10 years, maybe a little less. Was kind of getting bored, but had the opportunity to go to Albany Med and do some research on cell migration, on artificial and biologic scaffolds. So it was. So I took that time. I just basically sold my practice and took that time to go to Albany and spent 3 years up there looking at how fibroblasts migrate on scaffolds, how scaffolds can reduce contracture and scarring, and and what makes fibroblasts basically signal, what causes them to signal. And it was such a good experience that when I came back into practice, I was recruited by the local hospital here in the Poconos, and I worked as the medical director for the wound care center. Was hyperbaric trained, so we had hyperbaric chambers, and I had my practice inside the hyperbaric unit, and was basically the medical manager for the unit. I did that for a couple of years, and then was recruited by the plastic surgery group to come in and develop a limb preservation center for them. So everything kind of fell into place over time. Uh, and what they really wanted is somebody that could guide the family doctors that worked in the practice into wound care. So I had the opportunity to train them, and it was fun for me. I would take them into the OR, give these guys surgical experience, and they got to be quite good. Typically, it took about 6 months to get these guys trained up to be able to do adequate debridement and to treat wounds effectively. And then I obviously did the carpentry for the Charcot work, and working with two young plastic guys from Columbia who did all the muscle flap and soft tissue work. So that's where we really got into that whole orthoplastic approach, looking at wound care as more complex than just a superficial debridement. Of course, I've worked with a plastics group. I was, basically trained. I had some additional training on how they look at wounds, and all of those guys will do excisional debridement initially on all diabetic wounds, which I found to be pretty effective. So what you're doing then, as long as the perfusion is good, because in our group we also had an interventionalist, and we also had a very tough internist that got the protoplasm of the patient right. This multi-specialty practice is key. But when you do an excisional debridement, you're taking that chronic wound with all the non-viable tissue, and you have an acute wound. And as long as the perfusion is good, then you can heal it. If the perfusion is not good, you have the opportunity to do a reverse muscle flap. There's all kinds of opportunities. But I think sometimes in wound care, we look at wounds too simple. You can't do 3 days of training and be a wound care doc. It just doesn't work that way. You really have to have surgical experience. I mean, this when we do research, the centers that I try to pick, the sites I have to pick are guys that I know, plastic surgeons, podiatric surgeons that will do adequate wound care. That way, you can get effective research results. So it's been an exciting ride actually all the way through. But that's really what got me into it is looking at the complexity of it and understanding that every one of these wounds is different. Every patient protoplasm is different. Etiology is different. The challenges of offloading. As a podiatrist, obviously we tend to do a lot of internal offloading as opposed to external, where if there's a bony prominence, we just go in and remove it. Um, and and those are all the keys really to wound healing, taking the pressure off and making the wound acute again, getting all that bad stuff out of there, and then stimulating these patients. Because even if the perfusion is good in a diabetic patient, they still have a protoplasm issue. So bringing in the right technology to stimulate that wound, to take it out of that chronic inflammatory phase, which even after a surgical excision, within 48 hours, it's back in that stage. So it's a balancing pH. There's so much involved in this. It's exciting because it's fun. It's fun to be challenged all the time.
Yeah, no, I think a lot of people used to look at wound care as this very simplistic specialty. But the more I've traveled and spoken to clinical teams and at the practice where I really learned the nuts and bolts of wound care with the clinicians, 80% of the wounds are going to be pretty straightforward, right? You modify one variable and the patient's body heals itself for the most part. But those
Correct.
20% are just fascinating. You have to figure out, okay, we've done everything. What other lever can we pull? you know?
A great example of that and a great story I have is my MA that was with me all the time. She would walk into the room when I'm with a wound patient, and I would just be kind of sitting there staring at the wound. And one day I walked out of the room, and she said to me, "What what are you doing? You're just staring." I said, "While I'm staring at that wound, I'm trying to figure out what the approach is going to be. You're processing.
Yeah.
Looking at the patient, you're looking at the wound. Um, it's fun, it's challenging, but she didn't understand why I would just be staring at that wound.
it was your muse. And so, talking about challenging wounds and challenging situations, you've done a lot of medical missions. I didn't realize how many medical missions you had done. I know that you've done some in Haiti, the Dominican Republic, and the West Indies, I believe. What got you into medical missions and specifically medical missions around wound care? And what have you seen or experienced that is interesting?
Well, I think what really got me interested was after the earthquake. So that was I had just been a few years with the plastics group that I was working with, and I had a friend. Ernani Satterall, his name is a surgeon in New Jersey. He had called me and got interested in going to Haiti after the earthquake. They had a big need for wound care there. It was an amazing experience, to be honest. We did probably the most. Those couple of trips to Haiti, they're probably the most monumental and memorable experiences of my life. The first trip down, particularly in Haiti, it's a mass unit. You're sleeping in a tent with 180 people, and there's pallets so you can walk without getting muddy. And we were doing typically 10 surgeries, local anesthesia, maybe another 10 under general anesthesia every day. We had 60 vacs running. KCI donated all the vacs and all the vac supplies. So of all the units down there, the wound care units were the busiest. So the first time I went down, and I would say not strangely enough, but not so strange because of the experience that podiatrists have. Podiatrists seem to be the directors of the wound program when you would go down, and you'd have a couple-day transition, and and then you would take over. And then typically I had a number of nurses, physical therapists, and either dermatologists or other podiatrists that didn't quite have the wound care experience. And that was almost like a little mini residency. It was intense. The first time I went down, when if something happened in the unit and they needed me to get up and do it, they would walk into the tent and just yell out my name. Like there's 180 people sleeping there, and you'd have to get up. And eventually they numbered the beds, so next time I went down, they would just come and tap your bed. But that really got me involved. The treating the folks in Haiti, they're so stoic, and these folks didn't know where they're going to sleep that night. They didn't know when they were going to eat next. It changes your view of the world, and I think people that don't get outside of the U.S. or the Western world don't really get to see what the real world is like. And I think it's important. I think it's really important. That's what got me hooked. So I got involved with a group called Waves of Health, and the medical missions down in Haiti were with Medishare, with Kisner's group. And then I got involved with Waves of Health, and we did missions to Philippines and Dominican Republic, and then Grenada, which um, just you would think, well, it's an island with a relatively small population. Why would you focus there? Well, it's not just Grenada. All of the West Indies have the highest amputation rate for diabetic wounds on the planet. They have almost 100% amputation rate. So I got involved with St. George's University, and we were setting up clinics and we did set up clinics around the Highland. I was supported by TEI when I was still with TEI, and then Integra supported us for a while, and then they dropped the support, unfortunately. But we did get a clinic set up around the island, and I would go down with every month with I'd take one or two docs with me, and we'd have follow up on the patients, and that was unique for medical missions because medical missions you don't get to follow up. So being able to follow these patients every month, the nursing staff in the West Indies is old school nurses. They are amazing. they just you give instructions and they give it to the patients. The other thing I noticed too is how grateful the patients are on missions. Like when I would go back to Grenada every month, if the patient was non-compliant, they would come in and apologize to me and say, "And doc, I apologize, non-compliant." It's such a different experience, and that could just get you more hooked. So that's really where the medical mission side got in. So it was fun. I mean, we were at one point we were going to do, and I had other medical colleges in the Caribbean call me and say, "Can we set something up?" I take continuing ed with IUHS. They had called me. Ross had called me, so we were really looking to expand this throughout the Caribbean, but we just, at some point, I guess if I won the Powerball, I would just fund it and do it myself.
It's coming from South Africa originally, and seeing some of the under resourced communities, especially in and around the townships, um, they are so thankful to have any help, and to have world class help is just it's like a miracle for many of these patients, and especially the diabetic patients. I mean, they are just suffering, and you see them, and they have untreated wounds that had been festering for years.
Yeah.
You know, and it's the work that you've done in the Caribbean and abroad is just, I can only imagine the value that that brought to those communities, and hopefully you'll win the Powerball, so
Yeah, I
you
mean,
can go back.
that would be how I would definitely do that because there is such a need there, and I made connections there, and certainly St. George's University does a great job. It would be fun to not have to rely on a corporation to fund it, but just have somebody private to fund it where you don't have to worry about the funding being cut off.
So if you were to compare American wounds, we'll call them American wounds versus wounds that you saw on your mission, what were the biggest differences that you saw between the etiology?
A big diabetic population. And I think the biggest difference in the U.S. diet's pretty varied. The diet in the Caribbean is, and if they have six things on their plate, five of them are carbohydrates. It's just hard to control, and they eat what they can because it's what's available, and what's available is, mangoes and bananas and things that are inexpensive but high carbohydrate concentrations. They're very hard to control their sugar. And then, the access to medication too, with public health administrations are strapped for cash. And these countries are independent. They're not colonies anymore, so they're relying on their own people to take care of them. What they with the funds that they have, I will have to give them kudos though. The quality and dedication of the healthcare professionals down there is amazing.
That's amazing. So you've done a lot of clinical care, and I think that's when we met. We met in the realm of research. I did not quite understand how much work you had done clinically prior to that, and so as we were preparing for the show, it was really interesting to see the breadth of your experience and the work you've done. Um, Talking about research, so you're a clinician, you're doing medical missions, you're hand to hand combat in terms of wounds. What kind of drove your pivot into research and kind of focusing on that in the latter part of your career?
Well, I think what happened is that I started working in corporate. I went corporate from industry about 15 years ago. Because I had the clinical experience, typically they would just make me medical monitor on the projects that they were running. Um, Initially, some of as a medical monitor, you're looking at the research, you're looking at the wound photographs, and and the and the flaws that you would see in those, and then you're looking at the sites and evaluating the sites. I think trying to get accurate data that's real world is important. And like you and I have spoken about this, I think registries are becoming more important. I think retrospective data has always been frowned upon, but the reality is retrospective data is good data. And then with small companies, they don't have $3 or $4 million, or like Integra spent 18 million on their RCT. I mean, young companies, they can't afford that. So trying to develop a prospective study and picking sites where the clinician is more interested in the data than in the money became kind of an interest to me. So I've been able to set up some of those prospective studies we do, and it's good research, because really what you're doing is looking at how the product works. Now, with a prospective study, you're not going to have a control group, but you can always look at retrospective control. And some people may say that that's bad science, but others may say that I would disagree. The only difference really is that when you do an RCT, is that you have to have control of the standard of care as well. So you're standardizing the standard of care, and that becomes that, and that's what adds to the expense, plus cost per patient. It's expensive. I mean, ultimately, the way the FDA works now, and approvals work with CMS, RCTs are still going to be required. Just trying to find the most effective way to do it is going to be the challenge. And, I haven't spoken with CROs, and the cost of doing a 120 patient study. You're talking, like, if it's a 3-arm study, you're talking $3 million. That's a lot of money for a small company to put out. It doesn't have to be that way. If you can do these studies in-house and pay the going rate, I mean, all of the clinicians that I've talked to at the sites that we have right now are willing to work at the standard rate for patient. You don't have to gouge the system. So I guess a lot of it is just, I'm getting to the point in my life where if I see something that doesn't make sense, I just kind of say it, and we'll see where things go. And these prospective studies can be converted too. So if you start as a prospective study, you already have an inclusion exclusion criteria. You're just going to have to add in the randomization, and then the standardization of control. And so you've already got a study that's IRB approved. You can modify that study. It cuts the cost. You already have the blueprint, and you already have sites set up. So starting it as a prospective study and then rolling it into an RCT, I think makes good sense for a young company.
No, absolutely. And talking about some of the quasi experimental setups, a lot of people, to your point, look at the quasi experimental and go, oh, it doesn't replicate whatever it may be. But you find in even the randomized studies that they don't replicate to the field, right? Because the study is done under very constrained inputs, and the real world isn't constrained. you
No,
know,
I mean, a great example of that is, like, in my practice, if I was working with a patient that I was considering a procedure for, these folks come in with, A1Cs 13 and above. It's going to be hard to heal that patient. Then you get your internist involved, and you get that A1C down to something reasonable. Like somewhere around a 9.5 is probably reasonable. But the studies, if you try to control the study to get that kind of A1C, you'll never have any patients enrolled. So now you're starting with patients that are going to have really an unreasonable A1C. And for me, it's hard to intellectualize how any of this data is real. I mean, it's like when I was doing my research, I was looking at transcytosis of beta 1 integrins. So I was transfecting my cells. I was putting in labeled, you basically label a color onto the protein, and then transfect it into the cell. So I'm transfecting all these proteins into the cell, and then doing fluorescent microscopy to track the transcytosis, right? So I went to my PI one day and I said, "None of this data is real, is it?" And she said, "What do you mean?" I said, "Well, these cells don't have this natural amount of protein. I'm transfecting tons of protein into these cells, changing their whole cellular metabolism. how is that real? She didn't like that too much.
People don't like it when you start asking those questions. And I was working with someone on the statistical side of things, as you know, is where I spend a lot of my time. And
Mhm.
we had a variable that we were looking at, an endpoint. And I was looking at it and I'm looking at the shape and I'm like, this, I've never seen this in the real world, the shape, right? And they go, what do you mean? I said, well, in the real world, and I've seen thousands of these specific types of shapes, the tail on the right is very long. Your tail ends at 120. That's impossible. And they go, and finally they go, oh, well, we took out these people from the sample, etc. And I'm like, but you can't, then you've just
You've
invalidated.
manipulated the data. Yep.
And a lot of the time, though, to be fair, people don't realize what they're doing, right? It's kind of like, well, I'm trying to kind of clean up the outliers,
Right.
and statistical training in school's not great, right? That's what I've heard professors at school go, oh, just get rid of the outlier, without realizing that the outlier, especially in wound care, is where a lot of the information is carried. And so I think, to your point, as you kind of travel and you look at things, you start asking questions as to that data can't be real. It just doesn't make
Right.
sense. It's not representative of the real world. And I think in our conversations, what I've enjoyed is talking to someone who does this as a living, who's trying to get studies and information and really advance wound care, but at the same time being incredibly realistic with the people they work with to say, hey guys, if we're going to do it, let's do it the right way, and I've always admired that.
And that's always the hope. I mean, you're always going to get pushback. I mean, to me, it's just I like the idea of like you and I had talked about the registry system. Um, if you look at real world data, then you're just looking how these products work, what the time to closure is, or what the reduction in volume is over time in real world situations. I don't. The problem with research, clinical research, is the cost of clinical research is out of small companies that are coming out with exceptional technology. There's so much good technology coming out now, changes in advances in treating natural products like placental products. Um, New scaffolds coming out that are synthetic as opposed to natural, but just understanding what's necessary. I guess um, I mean, a good example of this is, if you look at every scaffold out there, and I've always been a big scaffold fan. Scaffolds are best as a temporizer. So if you have a full thickness, large wound, and you want to reduce contracture, so it'll slowly granulate in over time. That's what their best use is. Fibroblasts will migrate on any natural scaffold, but fibroblasts won't signal at maximum effect unless there's fibronectin on that scaffold. For instance, I'm to get a little wonky here, but that's a protein that's essential for fibroblasts to attach. When a fibroblast attaches to a scaffold, that's when they pump out everything they pump out at maximum capacity. So unless you add something to that scaffold to make it more effective, you know, it, it's just a scaffold. So for me, looking at all of these products and understanding that at each stage of wound healing, products need to be changed. It's not set up that way. It's a weird system. No one product is good for that wound throughout the healing process. You can never lock into one product and say, okay, I'm just going to use this until I burn out my 12 uses or whatever. If you use a scaffold, a good debridement, use a scaffold effectively, and let that scaffold granulate in, then you can move to something like a placental product that will bump that wound healing process from inflammatory to proliferative and get it to heal, or go to a skin graft. But there's always stages. I mean, working with burn surgeons, that's how they look at the world. They treat burns exactly like that. And then when they treat wounds, they treat their wounds like they treat their burns. So I think burn centers that are doing wound care now are definitely going to be more effective over time, because those guys are trained that way. They think that way. They say, well, no, I'm not going to use one thing forever. And then a lot of these products, using them every day. Like if you use for an example, if you use a placental product and it has chorion in it, you're always going to get some sort of foreign body reaction. If you use that product every week, you're going to get hypergranulation. You should understand that. So every doc should understand that. I guess the advantage I have is that when I go in with a rep, I can do the science with the doc, and we can talk about um, when this is best used and when maybe something else might be better. And I just gave a talk in Montana on exactly that topic, saying that guys need to know when to switch. You need to know, when to use what, and nobody talks about that. It's I think that's the change that we have to make in wound care right now, is that we get too locked into one product. And with all the new products out there, if every one of these products was used effectively, the cost would go down and CMS would save money. Um, it's just the right way to do things.
Talking about CMS, I mean, we had that whole brouhaha around the LCD, and everyone lost their mind quite rightly.
Mm-hmm.
But when I read the guidance that CMS had, it was very, to your point, very linear. You will use this product this amount of time, given this, this, and this. And I'm thinking to myself, is anyone who actually wrote this practiced in wound care? Because there's nothing linear about these types of wounds. And
No,
applying this linear rule.
that's a great point. People are making decisions that aren't clinicians, right? So if you've never worked in wound care, then you don't understand the process. So the people that are making these decisions, they don't know. I mean, I think if CMS were smart, they would hire, an experienced wound care doc to start making guidance decisions on the ability to switch products in midstream, the ability to move to another product. Why do we wait 4 weeks before we can use a product if this patient has had a chronic wound forever, and then you have to treat them? I mean, there's a point to that, just like a lead into a research project where, if you do a good debridement and there's good perfusion, yes, some of these wounds will heal. But the 20%, like to your point, that will not heal, why wait 4 weeks? Why just not like in a clinical research project, just wait, a week or two, and not let that patient continue to have this chronic wound with a chance of deeper infection and more pathology. Just move on to wound healing. CMS isn't set up that way, and it's kind of weird the way they are set up. And what they require, again, for these young companies that have great technology, just some of that stuff needs to be changed. I don't think you should require somebody to spend $3 or $5 million in an RCT that's going to give you manipulated data in many cases anyway, just to say, okay, you're in now. It's like pay to play. Doesn't make sense.
No, absolutely. And with the research that won't replicate to the real world.
Correct. Yeah, I think registries, retrospective data, even anecdotal data. If there's case series anecdotal data where a doc did 10 or 15 cases and got reproducible results, I mean that's all valuable data. There's nothing wrong with that data.
Well, as we've talked about, one of the issues is that there's this p hacking that goes on, right? People hack their way to that magic p value, and they say, well, there's a 95% chance that this works, without realizing that a p value isn't saying that. A p value is a declaration that the data you will see is, well, I'll have to say this very slowly because I confuse myself at times with this definition, which is a clear sign as to why it's wrong. But a p-value isn't that 95% of the time the data that you observe or the theory that you are proposing will be true. It is contrary to the null hypothesis, and it says that the data that you see will be more extreme than the null hypothesis if you were to simulate that infinite times. Well, even just saying it is confusing, right?
Right.
And so people hack towards that number and they say, well, we've got our number. And to your point, I think a lot of the research throws away anecdotal data or retrospective data, or even that the priors that people like you may carry about how a model should work. And one of the things that I'm being excited of working with you and working with other people is to use methods such as Bayesian methods where we can put this information into these models and then look at what the posterior distributions are versus a p-value, you know.
Right.
And I think that's what's really exciting is that the FDA actually is going to be is understands the Bayesian method, and next year they're releasing guidance on how they will accept Bayesian methods. And I think particularly in wound care, particularly because of the heterogeneity of the patients,
Correct.
but the heterogeneity of patients between time. The very same patient, to your point, can change incredibly over the lifeline of their treatment. So at time point 11, it's not the same person as time point 2.
Oh, exactly right. You're exactly correct.
So I'm very excited, and as I've taken a lot of what you've said and kind of been thinking deeply with other people that, in the clinical world about how do we statistically represent this heterogeneity that we see. Um, I You've said something really interesting. We talk a lot about pressure ulcers or arterial ulcers or venous ulcers. But burns, you've talked to me a lot about burns, and I've been incredibly fascinated by the burn world because I know very little about it. And you've talked a little bit about it, but compare and contrast the burn world or the burn patient base or the protocols. And you've done that a little bit already, but can you kind of dig a little bit deeper around that?
Well, I think the big thing with burn is for the majority of these patients are not, except for the burn, they're not sick, right? They're so they have good protoplasm. They're healthy. The majority of burns, about 65% of them, are deep partial thickness. So you don't have to worry as much about contracture because there's some percentage of reticular dermis remaining. So it's the wound is contracture is not going to be a big deal, but you still have to cover that wound because it's exposed for infection, which and a burn is just a wound, and stimulate quick growth of some sort of granulation tissue, and then move on to a skin graft. Uh, the more superficial partial thickness burns, they just typically put a skin graft on. So in burn, there's this movement now, and I was just at the Boswick meeting where in talking to some of the burn surgeons that I had dinner with and had time with, is to move away from using a split thickness skin graft in these patients and try to get um, a, some sort of technique. And I think placental products are probably going to play this role, particularly amniotic products, depending how they're processed, to stimulate a very solid ECM that will allow epithelialization to happen naturally, and that saves the donor site on these patients. You can also bring in a bigger wound, a CEA like Crecel or something, some other product like that, but that gets expensive. So, and burn centers run on a margin where it's a losing proposition. Basically, these patients cost more than the hospital can make on these patients. The burn centers are more altruistic. The burn surgeons tend to be a little they're clinically more focused on healing patients than about the money side. That's my enjoyment working with those guys. Is I respect them so much. But their model is to use is to spend as little money as possible on product. So, but you still need the products. So if you have a full thickness burn, then their goal is to put a temporizer in there. Temporizers come in a lot of flavors. There's synthetic temporizers. There's old line temporizers like Integra. But so then it comes down to cost. So then they'll look at and both the buyer and the doctor look at cost in these products. When you get to the partial thickness, it's going to be the same thing. It's going to be cost. So then it's working with the company and working with the distributors and trying to get to the point where everybody's happy on pricing, and you can fix the patient without breaking the bank, basically. So that's kind of the challenge they have is cost because they're dealing with big wounds. So, the average burn size is about 1,000 square centimeters. So it's not little wounds that they're dealing with. But these guys are very smart. It's fun talking to burn surgeons. A lot of them are plastic surgeons. Our dinner conversations are fun to have. They're interesting and a lot of good questions. And It's good. It's good. And then you're helping these patients. A lot of them, like when I was working in the Southwest, a lot of them are kids that come up from Mexico, and they're doing these patients pro bono. They cook over fires. Kids fall in fires. They get these burns. And again, most of them are deep partial thickness, but they have to be treated. And then they're lost to follow up, a lot of these patients. So you want to be sure when they leave, they're on the road to healing, because you're not going to get to follow. So it's an interesting business, the burn business. But I think, but it's wound care. I mean, basically, a burn is a wound. That's the bottom line. Uh, uh, what used to be called the third degree burn, which is a full thickness burn, is basically after you do sequential debridement and you've removed all the non-viable tissue, it ends up just being a full thickness wound. That's what you're dealing with.
No, that's super fascinating. When we had the nursing home consultancy, we saw very simple burns that you would experience at a nursing home. Now, a resident drops hot water on themselves or something like that, but nothing like the level of what you're describing with these pediatric wounds, or I'm guessing also a lot of occupational burn wounds, right?
Yeah, that's a big category, occupational. I remember the most severe case I can remember. I was in California with at the Grossman Center, which is now part of UCLA, and guy came in, worked at a chemical plant, fell into a vat of chemicals, 95% chemical burn, and there's still an attempt to try to save a patient like that, but at that point, at that level, it's just a matter of comfort. And but yeah, some of the stuff that comes in can be pretty nasty for these guys. But I totally respect that community a lot. I think they do everything. They seem to do everything right. And I think wound care could learn from the burn community.
Absolutely. I'd love to, you know, connect more, have the wound. It's a global community, right?
Mhm.
And I think to your point, the burn guys, because of the limited remit they've had, they've come up with very strong protocols because they've been very narrow in what they have to accomplish. And I think we could take a lot in the general wound care world where what's happening now, at least in my eyes, is that around clinical practice guidelines, let's say diabetic foot ulcers or pressure ulcers, there's a narrowing towards what has worked and what works, and the
No,
science is getting better.
and I agree. And I think the reason that a lot of the burn guys now are doing wounds is because, first of all, it fits the model for the hospital, because either a lot will come in or you'll have a big gap where nothing comes in. But in the meantime, there's all these wound patients, and these guys have the skills to treat them. So what I've seen, like in Boswick over the years, for instance, which is the big burn meeting in Maui, that meeting has changed, has evolved from a burn meeting to a burn/wound meeting. North American Burn, same thing. That meeting is evolving from a burn meeting into a burn/wound meeting, and these specialties are coming together, and I think that's good for wound care. I think it's good to have these guys involved, because they have so much to offer to the wound care community.
Absolutely. We've got about 10 minutes left, and I wanted to get to a subject that's kind of a little bit of a pivot on this, but um, biologics has grown incredibly in its use in the wound care community. And you were early in on this. I mean, you were writing things in 2006, the cellular basis for wound healing. You're presenting in 2010. And in 2013, I think you presented a paper called Review of Biologics in Wound Healing. And so you've been a decade, even more ahead. You know where we are with biologics right now. And I think there are incredible pieces of technology coming out that are
Mm-hmm.
really, really helpful. But then you have other actors in the field that are maybe not as reputable. Let's just put it that way. Um, where do you see this going, and given your view over the whole lifeline of biologics? And where do you think it is going? Where do you think it should go?
So that's a really great question. Let me start by saying every biologic that's on the market now works, or else it wouldn't be on the market. It's effective to some extent. I think that the biggest gap is the knowledge of how it works, and I think that's where I think we could play a big role, or somebody has to play a big role in explaining the mechanism of action on these products. I'll give you an example. A rep will come into a clinic and say, um, "We this product has 600 growth factors and cytokines." Let's just say, rep will say that, and then nobody ever challenges that. And I said, well, that's amazing. We should try it, right? Nobody asked the question, well, what are those growth factors? Or what are the concentrations? Are they physiologically, do you have enough concentrations to make it physiologically active? So those are questions that need to be asked. And not to I work with reps all the time. I love them. I love work. I learn more from reps sometimes than I do from anybody else. Some of them are amazingly astute and well educated, and they're great people. But they're working for a company, pitching the company line. But I think we have to educate them more on what's important, and then we should have. Wound care has very little backup for them. So I think the rep is the front line to me, but having somebody to be able, like I get called by these guys all the time with questions, and or they'll put me on the phone with the doc and I can answer questions. But a lot of companies don't have a backup for these guys. This role that I started with when I started with TEI wasn't even a role. Being a medical education director or whatever. It's like an MSL role, but kind of on steroids, because an MSL has science background. They can explain the science, but they can't connect the dots. As Carlos Santana would say, connect the molecules to the light. It's taking how the science works physiologically, clinically, because you have to be able to see how these products work. So having years of clinical experience and used all the different categories of biologics, I saw how they worked, and then having a little bit better background in science helps you understand why they work. So I think that has to be brought out. Then you would understand when to use the product. So I have a deep wound. I'm worried about this contracting, because if it contracts too much, it's going to be weakened and the recurrence rate is going to be higher. How can I prevent that? Those are the questions wound care docs should be asking. Or this wound is stuck in this inflammatory phase. What do I have to do? You have to change the pH for one thing, right? You have to get it out of that alkaline pH. And then you have to put growth factors and cytokines that the patient doesn't have anymore because of their protoplasm that will take them out of the inflammatory phase into the proliferative phase. So you're looking for specific anti-inflammatory cytokines. So, all these wounds have very high concentrations, for instance, of interleukin 1 beta. So how can we knock that down? How can we prevent macrophages from pumping those out? Well, you need to block the receptor that the interleukin 1 beta receptor. So which of these products have a high concentration of interleukin 1RA, the receptor antagonist? So it's not a lot of science, but it's enough to be able to use these products effectively. So a wound care doc should know that. He should say, okay, I'm stuck in this phase. What are the things that I can do to change this? And then you could pick the appropriate product. You look at their profiles. Take a look at what they offer. Take a look at how they're processed. A lot of these growth factors and cytokines are very fragile. They're not collagen. They're not a tightly bound triple helix. They're ribbon proteins that if you use any kind of heat or bleach or anything, it breaks them down right away. So you kind of should know all that stuff if you're a wound care doc, and add that to your clinical background. So that's where it's going. I think where it's going, and I would always say this anyway, because I'm an educator. I would say it's going to be education. You go to wound care meetings. There's not a lot of unless you go to WHS lectures. There's not a lot of science behind the talks there's some great meetings out there. The innovation meetings I think are awesome. The WHS lectures at SAWC are awesome, but those are lectures that give you that education. And because the other standard wound care lectures are the same every year. They're just standard wound care lectures. I mean, I won't mention names, but I've seen these guys speak, and it's the same talk every time. It's like there's no change in that talk. So go after the science. That's going to be the change in using biologics. You have to use them intelligently. or else CMS is going to take them away.
No, absolutely. I think you hit it on the head. It's interesting because I think we are at a place in wound care where, to your point, we have gathered a lot of anecdotal, historical methodology, and we've whittled it down and narrowed the science down to where we know generally what works on average. Where wisdom or expertise kicks in is where will it work, not on average.
Right.
Right? and
Yeah.
and that comes to what you described, knowing the science and really having that expertise to make the right decision at the right time. We've talked about this, but one of the things that is my passion is saying, okay, we've got the scientists who are really driving away at finding the right products. We've got the clinicians that are really getting good at the clinical science and really getting that nice, tightly wound and ready to go. But our statistical models or quantification needs to be up there in order to be more sophisticated, more flexible, to allow people to ascertain is there a treatment effect or not, right? Like
Right.
that's where, from a statistical perspective, I think we need to go. And it's really interesting sitting on one side of it and listening to someone like you saying, okay, let's get into the science, let's get into the chemistry, let's get into the biology, the microbiology. This is what's going on. And we should be able to articulate that quantitatively, you know.
Yeah.
So, yeah,
And accurately. I mean, you should do it quantitatively and accurately, right?
absolutely. So we got about 2 minutes left. And, in closing, a question that I've asked every other guest, and I think you touched on this a little bit earlier before, but if you had a wound genie, you're reading Wound Arabian Nights, and the wound genie comes out and can grant you any wish in wound care, any one wish, what would you wish for?
I wish to have colleagues on my team that could fix the issues that are my concerns, for instance, perfusion, as an example. And I'd like to be able to use any product at that specific time that I need it. And if I was able to do that, I would use less product, but not have these ridiculous rules where you stick with one product and use it 12 times and then you have to wait till you use the next. It's just not wound care then. Then you're restricted by rules. I think and I'm a surgeon, but I think wound care docs, especially with a surgical background, they don't want to be restricted by rules. That's where like the burn guys, they're not restricted. They go for it, But that's what we need. We need to be able to. We need to have more freedom, and I guess the problem with that is if you give too much freedom, you're always going to have that percentage of clinicians that are more in for the money. And I hate to say it, but you and I see it. It's frustrating. It's not the oath. The oath we take is to do no harm, and doing something for the money is just wrong.
No, I can't agree with you anymore. And the concept of that clinical liberation, right? The emancipation, do the right thing for the patient at the right time.
Right.
And I think what is interesting in the conversation, and again, there are financial constraints. Absolutely.
Mhm.
We all get that. But I've talked to a lot of people and I've said, you do know if you force someone to make a bad decision at an earlier time point where you're saving cost at that particular time point, you can incur more cost in the long run.
Absolutely. That's absolutely a great point. I mean, that's exactly what you're doing. I mean, the idea is to keep these folks from getting amputations, right? Particularly the diabetics, right? Even the venous patients, they're not. You do an appropriate compression is a good example. I mean, there there's inexpensive compression techniques that work better than the expensive ones, but for some reason the expensive ones are the ones that are being pushed. So not to get into specific examples, but it's really just understanding that there's all kinds of techniques out there. Just get out there and constantly learn. But a wound care doc has to constantly learn. They have to be educated constantly. I think the meetings could do better, but the variety of meetings that a wound care doc goes to, I think, is helpful. So that's my suggestion to all the wound care doc guys out there: go to a burn meeting, particularly something like NABS or Boswick, or even one of the regional burn meetings, and go to their lectures. Go to the innovations meetings where the new products are coming out. see what's coming down the road. I mean, all the synthetics and everything that's coming down the road. Be educated. SAWC, good conference, but it's not the only one out there. You could mix it up a little.
No, absolutely. Well, thank you so much. Our hours come, and this has been an incredibly interesting conversation. I always enjoy speaking to you, and I'm still astounded at times by how much you know about the science and the education and the history that you've had in wound care. And again, I think our viewers and our listeners will have learned a lot during this. So I really appreciate your time.
Oh, thank you so much. It's been enjoyable. Yeah, no, it's been a great ride. Wound care is an awesome field to get into. Just treat it with respect.
Absolutely. Thank you so much, Dr. Starinski. And again, thank you for the past hour.